Okay, today we're going to talk about peripheral artery disease, or as we call it, PAD. PAD is actually more common in men, and the extremity that is affected the most are legs. Couple terms that you need to know: arterial sclerosis, and that's whenever the walls become thick. It's what we know as hardening, so to speak, of the arteries, and atherosclerosis, which is almost always with it. They go hand in hand, and that's just the accumulation of lipids. For the pathophysiology, this is what a normal artery looks like, and a narrowed artery is there on the screen on the right. Um, the most common result of arteriosclerosis is stenosis of the lumen of that vessel, obstruction by thrombosis, an aneurysm, ulceration, or a possible rupture. The most common arteries that are affected are the abdominal aorta, the common iliac arteries, and the femoral arteries, and any artery below the knee. In regards to there's a chart in your book. It's on page 829, and it is chart 30-2. And this slide just shows you risk factors for PAD. The first one there, Fat Albert, obesity, is a problem, as we know with any vascular disease that we've discussed this semester. Smoking, and that is due to the nicotine. Okay, it's one of the most important risk factors because we know that nicotine decreases our blood flow by constriction, and it also increases platelet aggregation. So that would increase of getting a clot and having obstruction. Hypertension plays a huge part in that. Our hyperlipidemia, your diet, contributing to hyperlipidemia, so we want to make sure that we're monitoring that. And then diabetes. We know that diabetes and cardiovascular diseases, any type of vascular disease, goes hand in hand. Diabetes actually speeds up the thickening of the walls in this disease process. And by maintaining or trying to not smoke, trying to keep your weight under control, good nutrition, they may not actually prevent PAD from occurring, but they will slow the progression of the disease. So there's no for sure cure or prevention for any disease. We know that some people who live the perfect healthy life and they still get diseases, but these are definitely risk factors that play an important role. So a symptom of atherosclerosis is known as intermittent claudication. It's the hallmark sign or the hallmark symptom. It's a cramping pain in the leg that's exercise induced, and it's caused by obstruction to the artery. It is usually relieved with rest until the disease progresses, and then rest may not relieve it. But intermittent claudication, by definition, is a cramping pain in the leg that is exercise induced, caused by the obstruction of the artery, and it's usually relieved with rest. Alright, as PAD progresses, patients will even have pain at rest. Ischemic pain is often worse at night and can actually wake the patient up. It's very painful, and elevation of the leg causes pain to increase. So many patients will actually sleep with their legs out of the bed or hanging off the bed in a dependent position. So here's your why question about this slide. Why do you think that if my legs are elevated that I would have an increased pain versus if they were dependent and having relief of pain? So you need to think about that. Pause this PowerPoint, think about why you believe that to be true, and then resume your PowerPoint for the correct answer. So hopefully you've resumed the PowerPoint and you've thought about this, and the conclusion that you came to is what you know about veins and arteries, that our arteries take oxygenated blood from the heart to our tissues versus the veins who take the deoxygenated from the tissues back to the heart. So if I have a blockage in my lower extremity and I'm trying to get oxygenated blood down to my toes, but there's a blockage somewhere between my knee and my ankle, then I'm not able to get blood flow down there. So if I hang my legs off of the bed, gravity will help that and hopefully get some oxygenated blood down to the tissue, because we know that if we have tissue who's not receiving oxygenated blood, then we could have cell death, and that means pain. So that is why with PAD or arterial insufficiency, the legs are in a dependent position, versus when we had talked about venous insufficiency, it's the other way around, that we keep our legs elevated. This slide just shows you the stages of PAD. Stage 1 there is when we start to see reduced pulses. In stage 2, that's when you start to notice the intermittent claudication. By stage 3, they cannot even rest to relieve the pain. It's continual pain. And in stage 4 is when you see the ulcers start to develop. These are just pictures that show you what the extremities would look like with a patient who has PAD. The picture on the right shows that the feet are elevated and they'll be cool, pale looking. Alright, and that's because what we just discussed, that if our feet are up, then we're not getting the blood flow that we need. The picture on the left is a color that we call rubor, or a ruddy color, and that is normal to see with PAD. That's due to the inflammation that's occurring in the tissues, and we're trying to get blood flow down there. So this is normal, and this is what you're going to see with a patient who does have PAD. This is showing that there's tissue injury, pain, swelling, redness. Those are all signs with the patient. The pulses may be diminished or actually absent. They may not have any pulses at all. These are other pictures of what you may see with a patient who has PAD. The top one there are the nails that are thick and opaque in color. Okay, and that's due to not receiving enough oxygen and nutrients down that far. The bottom picture there shows that the skin is dry. It's atrophic, sparse hair growth. Okay, all those things occur with a patient with PAD. Also, when we suspect that there may be some type of a blockage, or that the patient is not getting blood flow to the extremity, one of the best ways to determine that, obviously if you have signs this late in the game as this picture, you're going to know something's up. But if it's in the beginning stages and you're trying to figure that out, you would want to compare the leg that you feel that's affected with the other leg to see if there's a difference. Because if there's a clot in the left leg, you can check, is there a pulse in the left foot versus the right foot? Is the foot cool on the left versus the right foot may be warm and normal feeling? Is the color more pale than the right foot? So if you're not for sure in those beginning stages, then you would want to compare your extremities. A lot of time walking programs are suggested for patients, and a lot of time that helps. Just exercise that they start out slow and eventually work up to a bigger pace. That is one of the things that we work toward with these patients. But sometimes meds need to be used, and those medications that you'll see used a lot of time are Plavix and aspirin, which are considered to be antiplatelets, and they're used to prevent the thromboemboli. Also, Trental or Pletal are drugs that we use for intermittent claudication. Trental actually decreases the fibrin levels, and Pletal has vasodilator properties that inhibit the platelet aggregation. So those are the medications that you usually see given with. So with patient teaching, arterial dilation promotes blood flow, and therefore this is the goal for our patient with PAD. We want to teach our patient all these different things. We want to avoid cold temps because this can cause vasoconstriction. We want to make sure that we have adequate clothing and warm temperatures to prevent them from chilling. The stress, that we know that causes constriction. Our sympathetic nervous system kicks in and it causes vasoconstriction. We want to make sure that our patients know, do not cross your legs, because that can cut off circulation. Tight fitting clothing like socks. Okay, we want to make sure that our feet are kept clean and dry, and that we don't have the circulation cut off by the top of the sock. heat may actually increase our metabolic rate and increase the O2 demand, and the flow is not adequate to meet the need. So we have to make sure that we watch that fine line in between there. Heat needs to be used with caution. Has to be used, but with caution. And then also making sure that our patient has proper nutrition and fluids. This is a picture of necrotic toe, and this is what can actually happen if we do not correct PAD. Okay, poorly perfused areas can result in this, and there's no coming back from a necrotic toe. This is surgery and debridement, so we can't fix it once it's gone this far. We want to avoid trauma because we know that trauma can lead to this, so trying to protect our extremities the best possible way. Segmental Dopplers and ABIs is what we do to confirm that the patient has PAD. They combine Doppler ultrasound with blood pressure measurements at different locations on the limbs. And by comparing those different readings, it helps to diagnose an arterial blockage. And the ABI stands for ankle brachial index, and that's when they take the ankle and the brachial blood pressures and they compare those. So you'll see these exams done. The vascular docs usually order these procedures, and that's how they determine the arterial blockages. I believe they put those cuffs around the ankle, the brachial, the thighs, the calf, and possibly even your toe to get different measurements during that exam. This is a picture of an arteriogram in the lower extremities with angioplasty. You guys already have discussed coronary angioplasty this semester, and so hopefully this is just a quick review for you. It's the same concept. They go in, they shoot the dye down both extremities so that they can find out where the blockage is, just like they do in the coronary arteries. Balloon angioplasty and stenting is done the exact same way. They can slide the balloon in, open it up, or place a stent if they need to do so. Bypass grafting. One of the ways that we do this is a procedure called a VOPP. VOPP standing for femoral, POP standing for popliteal artery. You can look on the picture there on the slide. Shows you where your femoral artery is, where the blockage is, where the popliteal artery connects, and then on the picture to the right there, it shows you how they take a graft, put it in above the blockage, and then reconnect it below the blockage in order to get adequate blood flow, and that's called a VOPP. There are many different procedures that we can do, FEM to FEMS, okay, bilateral VOPPs. There's many, from artery to artery is what we're doing there. Surgery is for the severe or disabling claudication, so this is our last step, so we will try all the others before we actually take them in and do surgery. Our highest priority assessment postoperatively is looking for graft occlusion. These patients are at risk for graft occlusion, and how do we check that? We check that by looking at pulses, looking at the color and the temperature, their capillary refill. We would compare left extremity to the right. We may have to use a Doppler. Those are more sensitive than just palpation by our fingertips. So all of these things are what we do. If you have a right VOPP, then you are wanting to make sure that you have pulses on that right side, and you can check the color and the temperature by looking at the left side and seeing, is there a huge difference here? Have I lost pulses since this procedure? So it's very important that we're watching this postoperatively. This is the expected appearance postoperatively of what the leg is going to look like. We're getting blood flow back to an area that didn't have it before. You're going to have a little bit of inflammation, and again, this is called a rubor or a ruddy color, and that's a normal appearance that you're going to see directly after surgery. We want to promote graft patency, and two ways that we do that is controlling our blood pressure and adequate hydration, because we know that nutrition and adequate hydration will promote healing, and that's our goal here. A complication that can occur is known as compartment syndrome. Usually when we talk about compartment syndrome, it's referring to casts or splints. It's usually referring to some type of orthopedic procedure, but it also can occur with PAD. It exerts pressure within a confined space, and that compromises the blood flow and decreases tissue perfusion. Full damage can occur within hours of compartment. Be aware that this could happen and look for the signs and symptoms of it. When you are thinking about circulation assessment, I want you to think of the 5 P's: pain, pulse, pallor, paresthesia, and paralysis. Make sure that you understand what each one of those are. You know what pain is. You know that we're assessing for a pulse. We know that pallor means color, so is it pale or is it white? Paresthesia, can they feel? And paralysis, can they move? So the 5 P's when we're talking circulatory or circulation assessment. Pulselessness is actually a late sign. So we need to be looking for all the other signs that are occurring when we start to lose a little bit of the temp starts to get cooler, when the color starts to get a little bit paler, before we actually lose our entire pulse. Compartment syndrome treatment, things that are what we do to fix that. Surgical decompression of the fascia, which is the band of tissue fibers. We go in, and this picture here shows you what they actually do. They will actually cut the lower extremity, usually in 2 different places down each side, and when they come back from surgery, the leg is actually left open. The reason that it's left open is because of the swelling. That's what's causing the compression in the first place. So we leave that open so that the leg can open up, swell, drain, and then as we get the condition under control and the swelling starts to go back down, then eventually they'll take them back to surgery and try to close up if they need to. A lot of times that will heal from the inside out, but a good portion of the time they lose part of their extremity from this. So it's a very, very serious condition, and it could actually even lead to amputation. So this is just a picture of all the different areas that we do lower extremity amputation. Amputation just means it's a removal of our body part, most often a limb. Again, I don't care that you guys know statistics, but just to put this in perspective for you, approximately 82% of amputations are from vascular disease. So over 3/4 of the amputations that are performed are due to poor circulation. Now, obviously, there's car accidents and logging accidents and traumatic amputations that occur, but most of them are due to vascular problems. And 1 in 200 Americans have had some type of an amputation. Maybe a finger, maybe a fingertip, maybe a toe, maybe a whole leg, but 1 in 200, and that's pretty big number. They're always performed at the most distal point that will heal successfully, and the site is determined by 2 things: circulation in that part and functional usefulness, which means does it meet the requirement for a prosthesis. Most people can eventually be fitted with a prosthesis. This picture shows you that a guy has bilateral prosthesis and he's gone on to do great things. And I think this guy actually has done some illegal things. I think this is a picture of the guy who killed his wife, but he's also in the Olympics there running. So just to show you that prosthesis work, people go on to accomplish great things even though they have lost limbs. We always try to save the knee and the elbow joints because they have better healing and better usefulness if we can do that. Things that we may see with these types of patients if we have an amputation: obviously infection. We just had surgery, so we have a huge risk of infection, and hemorrhage. We have surgery, we have a chance of bleeding. The big thing that I want to talk about though is phantom pain, and that's caused from the severed nerves. About 60 to 80% of patients actually experience this. Not all do, but a good portion of patients actually experience phantom pain. And what that means is that we have removed the leg, but the patient still believes that they have the leg. They still have sensations. Like if they've had a right leg amputation, they may still feel that their right foot is itching or their right calf is hurting. So they still have that sensation even though the leg is not there. This is a good link to watch to understand how mirror therapy works. This is one of the things that we do with patients who have phantom pain. If the right leg was amputated, but they feel that their right foot is itching, then they will place this mirror next to the left leg, so it gives the illusion that the right leg is still there. And if they can do to the left leg what they need to do to the right, and it appears that they're doing it to the right, sometimes they have relief from that. So this is something that you may see done often. It's not a cure, it's just a fix for the problem at that time. We put on the compression stockings, or sometimes you'll hear these as stump shrinkers in the hospital. These control limb edema, and we use them to help shape it for possible prosthetic fit. So this is what they look like in there. Directly post-op, this is not the position we want our patients in. We do not want their legs elevated like that. I want you to stop this. I want you to think about it for just a minute and try to understand why directly post-op, if my patient had an above-the-knee amputation, and by the way, above-the-knee amputation, you will see abbreviated as AKA, and if we have a below-the-knee amputation, you will see that abbreviated as BKA. You need to know those abbreviations because they're very common. I want you to think about, if I have a left AKA, why would I not want my patient laying in this position that you see in the picture? Why do I not want it elevated? So think about that and then come back to the slide. So hopefully you've paused this, you've thought about it, you've come back to the slide, and hopefully have come up with the conclusion that we do this in order to prevent joint contracture. Positioning plays a very important role postoperatively with these patients. Initially, when the patient comes directly out of surgery, you may actually see the surgeon have the limb or the stump on, or the amputated limb elevated on a pillow for a few hours just to promote or decrease swelling and promote some healing. It does not stay that way very long, so don't get confused by the fact that that happens directly after surgery. We want them to keep that limb straight so that we don't cause a contracture. So if I have a left AKA, then I could have a contracture on my left hip, and I don't want that joint to be contracted. So that's why we actually lay them in a prone position and not supine with it elevated. This is actually the correct position that we would try to lay our patients in to try to prevent contractures from occurring. And that's it for PAD.